Okay, good afternoon, everyone. Thank you for joining us. My name is Garrett Schmidt. I'm the managing editor for ACO Exhibit Hall, and I'd like to welcome you all to today's webinar by Clinigence Health called Strategies to Optimize ACO Performance. A few items of housekeeping before we get started here. All attendees have joined the webinar today in listen-only mode, so you don't have to worry about muting your mic. That'll be done for you. I would also like to tell you that this webinar is being recorded, so you'll have the opportunity to rewatch the session and or share it with your colleagues and friends. A link to the recording will be emailed to you following the presentation, and so I'll be sending you an email and send you a link to that. And finally, during the webinar, you can submit questions anytime. You don't have to wait till the Q&A session. So you can submit those to our presenters using the attendee control panel, and we'll answer as many of those as we possibly can during the Q&A session at the end. And these questions are also being recorded, so even if we aren't able to get to yours today during the allotted time, then we will follow up and make sure to do that via email afterwards. All right, without further ado, our presenter today is Dr. Lawrence Schimmel, who's the Chief Medical Officer of Clinigence Health. Welcome, Dr. Schimmel.
Thank you very much, Garrett, and thank you all for taking the time to meet with us today and listen to our presentation. For those of you that know something about me, you might wonder, what is a general surgeon doing talking to a group of people regarding optimization of ACO performance? Once I stopped practicing, I jumped into the analytics world and spent a large amount of time with payers, providers, and all different kinds of provider organizations. Subsequently, that led to the creation of Clinigence Health. And as you can see on the slide, we're a healthcare technology company headquartered in Atlanta, Georgia, with offices in other areas of the country. And we provide resources to payers, ACOs, other provider organizations, clinically integrated networks, etc. Today, we're going to focus in primarily on the ACO, and my focus is trying to show you how we can efficiently use resources to deliver quality care, which at the end of the day will allow you to reach your financial benchmarks and goals. This was the cover page as it relates to the information that was sent out, so I will skip past this. This is the conundrum that we're all in, whether you're a payer, whether you're a provider, whether you're an ACO, is everybody rowing in the same direction? Is everybody part of the team doing what's best for the organization? And I believe, and I think many others believe, that the key to getting everybody to work together and row in the same direction is to provide transparency as it relates to data, so that whether it's the managers, whether it's the individual provider, whether it's the care manager, whomever it may be, can have the information and be able to share it with the individual providers so that they will understand what needs to be done to get everybody rowing in that same direction. So this is what's happening in healthcare today. We're moving from what was totally a fee-for-service system to what's totally going to be a value-based reimbursement system. I can't tell you what that timeline is, but I can tell you that we're right in the middle now in that revenue transition period. And whether you're dealing with a risk contract or an ACO, you have benchmarks and your financial parameters that you have to meet. It's how you care for the patient that determines whether or not you're able to meet this. I believe that this transition period allows ACOs the opportunity to implement procedures and strategies that will increase the quality of care and reduce the overall cost of care. We all know that the more the doc does, the less you're going to be spending on ED and hospital, etc. So this transition period that we're in, and for whatever number of years it continues, it's critical in realigning the strategies and realigning the emphasis on the primary care physician in the care continuum. The second thing that I think we all know is that healthy people don't cost a lot, and people with multiple chronic illnesses and or other comorbidities cost a lot. And then in the middle, you have these people, and we can call them in the transition period again. They might have a single illness, single chronic illness that's non-complicated. Take diabetes mellitus type 2. Non-complicated diabetics would fall into this yellow. But if you had a type 2 diabetic with retinopathy, kidney disease, vascular impairment, and ulcers, then all of a sudden their cost of care moves over to the red side. So what's important is the identification and the segmentation of your patients so that you could engage with those patients, that you have an opportunity to change their arc. Another thing that a lot of times is not recognized is that the doctor or the physician with their pen control almost 100% of all the healthcare dollars that are spent in the United States. The other thing is physicians right now only receive 15% of all of those healthcare dollars. So it's kind of ironic that the provider of care receives the vast minority of the dollars spent, but at the same time controls with their pen where all the dollars are being spent. So it's critically important to connect PCPs to actionable information regarding their patients. A lot of times you can sit down with the doctor and say, Doc, I think your ER rate is too high. And the doctor will say, show me. So that if you can provide the data, if you can show them the data or share the data with them, that will be critical. So I believe that providing physicians data allows them to engage with their patients, and the best patient engagement I can identify comes from their PCP, comes from their doctor. Physician engagement touches medical utilization and expense. It touches population health. It touches the quality of care, and obviously it touches patient and member engagement. Now, to efficiently do that and to not spend hours on end searching through the voluminous amounts of data that you get, technology is that bridge to efficiency. So whatever technology platform you work on should enable data transparency. And in the ACO world, the payer is CMS, and the provider organization is the ACO, and the provider is those doctors or TIN numbers that are providing the care. So ideally, you want management of the ACO to be able to see the data quickly, and ideally you want individual provider groups within your ACO to be able to see how they compare year over year and peer to peer. A lot of the providers that are in your ACO, and in some instances, say clinically integrated networks, they may have more than one contract. They may have an ACO here, a risk-bearing contract there, whatever. You don't have the patience or the ability to run multiple different platforms based on contracts. So your ideal technology should be able to manage multiple contracts, whatever they may be, on a single platform. It's important to be able to see how your provider is performing in relation to last year, and it's also important to see how they're reporting to their peers. If you were just going to go to them and say, listen, you're not doing as well as these 4 doctors over here, they're going to tell you my patients are sicker, my patients are different. But if you show them this is what you did last year and this is where you are this year, and you're either better, worse, or the same, that's a more meaningful approach to engaging your physicians. You need a holistic view of data across the whole care continuum. And what do I mean by that? Well, you can think of the different things that happen to a patient on a day-to-day basis, whether they be imaging studies, whether they be ED visits, whether they be admissions, whether they be readmissions. You go down the list of all the things that occur to a patient, and you should be able to see how those patients are as it relates to every one of those services, and which doctors are your outliers as it relates to those specific services. When you get that kind of information, you can engage patients. If you have X number of patients that have higher ED per thousand rates than others, you can engage the doctor who belongs, or the patient belongs to, and more importantly, then have that doctor or somebody else engage that patient. I think a predictive model is critical. Now, they're all different kinds of predictive models. Within the ACO world, you're looking at MRAs and HCC scores, but that's just telling you relative risk of a patient compared to all the other patients in the country with similar comorbidities or morbidities. A predictive model like the Johns Hopkins ACGs, you may not want to look at the risk score per se, but a model like that segments your population, whether it be by risk or by predicted cost or by likelihood of hospitalization or likelihood of ICU or likelihood of care coordination issues. All of that's critical for your population health and care managers, so they could address those patients that are the ones where a little bit of effort on your part can dramatically change, again, the arc of what's happening. And in an ideal world, your technology should allow your provider groups to access their own data so that they can see how they're doing, and then they, even amongst themselves, can determine that they need to perhaps change the way they do things. Now, important ACO measurements. This is an accumulation of bullet points that I got by reviewing the Inspector General's report for high-performing ACOs in the United States from clients that I've dealt with and their chief medical officers and past experience. I think year-over-year performance for the ACO and also year-over-year performance by TIN number are critical. Are you getting better? Are you getting worse? Or are you staying the same? And then, did we spend less this year than we did last year? Again, to meet your financial benchmarks, you need to spend less this year than you did last year. Readmissions, hospitals have always talked about 30-day readmissions, but in reality, the 90 and 180-day readmissions, they're the ones that could make or break you financially. And high-performing ACOs have a target of less than a 50% 180-day readmission rate for people with chronic illnesses. Now, the fourth bullet point is something that I hadn't thought about until I was in a meeting a few weeks ago. And the chief medical officer of this high-performing ACO said to me, "We see our patients 4 times a year, especially chronic disease patients." And he said the reason we do it is we can identify people that are deteriorating. We can identify people that haven't filled their prescriptions if they're getting 90-day refills. We can have a better relationship with our patient so that our patients won't disappear and leave us as it relates to attribution. So this particular ACO makes it a rule that every chronic disease patient has to be seen 4 times a year. And they set up these visits when they do the care plan following the annual wellness visit. Pharmacy gaps, you want to know which patients aren't refilling their scripts. It's critical because it's one of the more important reasons for complications of a particular illness and or admission to the hospital. The annual wellness visit, the statistics vary, but a lot of the ACOs in this country have a less than 20% annual wellness visit rate. If everybody that's in an ACO, and I know ideally that's not going to happen, every patient had an annual wellness visit, the vast majority of your quality prevention measures are already taken care of. So it's the annual wellness visit, what sets up the care plan and sets up your follow-up visits with your patients, etc. Prevention management and screening, we all know that that's important. And again, the gaps that may exist that you identify after your annual wellness visit is what needs to be filled during those visits, especially hopefully those 4 visits a year. Transition to care. Every patient that is discharged from the hospital home should ideally see their PCP within 10 days. Those patients that do not see their patients those patients that do not see their PCPs within 10 days have a significantly higher readmission rate than those that do. The other measurements are ER visits or ED visits per 1,000, admissions per 1,000. You need to focus on patients you can help. Again, the model that you use could segment those patients with multiple comorbidities or are end stage or for whom there's very little that can be done except make the best use of the resources that are needed to support the patient. Your focus should be on those patients that can be helped the most. MRA scores, obviously, that's important for operation. We'll get into that in a little bit. And patient retention. You want to keep the same patients. And one of the tricks to keeping the same patients is that doctor-patient relationship. And that is built by the doctor seeing their patient, again, a minimum of 4 times a year. Now, the 3 key questions that everybody has to ask: are we improving? Are we staying the same? Or are we getting worse? If you do nothing, there is a high cost associated with it. If you have a type 2 diabetic that's not coming in for their A1 hemoglobins and they get diabetes out of control, there is a high cost as it relates to quality of care and basically the cost of the care that's going to be required to bring that diabetic back into control. If you have somebody with COPD and you're not following them, whether it be with PO2s and incentive spirometry and other things, there's a high cost of doing nothing when they deteriorate and end up hospitalized and or on a ventilator. So doing nothing is really not an option. It's important to address patients before they have the problem so that you can basically improve their lives and their care, and at the same time your overall cost of care is going to be reduced. So annual wellness visits. Are you improving, staying the same, or getting worse? We know that it helps increase quality scores. We know it helps you identify who you need to focus on and in the development of care plans. And we know statistically that those patients that have an annual wellness visit, even without the rule that I want to see my patients 4 times a year, those patients see their doctors more. And that's a national statistic. Now, why do you want to see your patients every 3 months, especially those with chronic illnesses? Well, you want to identify issues before they occur. If you're following the patient, you can see deterioration in somebody with COPD. You can see weight gain in someone with congestive heart failure. You can see people that are getting out of control as it relates to their diabetes. You can see people that are having deterioration of their kidney function because of diabetes. So there's no question seeing patients more often will help in the long run. Seeing your patients reduces visits to the ED. If you're seeing your patients and you're addressing their issues, they don't have to run to the ER. And 50% of all patients that end up in the ED end up with an unnecessary admission or an admission, many of whom are unnecessary. You see your patients frequently, you increase your prevention and quality measure performance. And last but not least, you know which patients are filling their prescriptions and which ones are not. So that's a critical component. Transition of care. We know that the basic best medical practice is see your doctor within 10 days if you're discharged. In the old days, we relied on the patient to make the appointment. Today, we have to be proactive and we have to engage with patients that we know were admitted to the hospital and we know that were discharged. We all know that the likelihood of readmission decreases as the percentage of transition of care visits increase. And then the other thing that's important regarding transition of care is you want to reduce your, reduction in a skilled nursing facility and rehab transfers back to the hospital. There are ACOs that engage with SNF and rehab physicians to work with them to try to prevent that. Now, readmissions to the hospital. Hospitals and the hospital statistics are really, what's my 30-day readmission rate? And that's all the hospitals cares about. If they get someone into a skilled nursing facility and they get readmitted in 31 days, it's no harm, no foul to the hospital. But as it relates to your overall performance as an ACO or a risk-bearing entity, it can be critical. So we need to measure the 30, 90, and 90-day readmissions. We know that 50% of patients that are discharged will be readmitted, especially if not seen. National statistics as it relates to congestive heart failure, this is what the 30, 90, and 180-day readmission rates are. Now, how do you reduce that readmission rate? One simple thing, again, we're going to get into this in a little bit, but give your patients a scale. If the scale happens to be Bluetooth, you can do remote patient monitoring. If it doesn't, the patient can call you if the weight goes up quickly in a period of days. So there's a lot of things that we can be doing proactively to prevent readmissions to the hospital. Patient retention, the higher the percentage of patient retention, the better the overall performance of the ACO. That comes from the OIG. And it seems to it's intuitive. If the patients remain in the care of the doctors whom they're attributed to, they will see the patients more and they'll engage with the patients more. And the other thing you have to accept is if you don't see a patient within 6 months, they have to be considered lost. And that percentage you want to be as low as possible. As far as ED visits and admissions, 50% of all ED visits result in an admission. Think about someone with COPD, congestive heart failure, ischemic cardiovascular disease, go down the list, and they show up in an emergency room at 6 o'clock at night. There is a 50% chance that all of those patients are going to end up being admitted. And I would dare to say that on holidays, weekends, and after 5 p.m., that percentage goes way up. And during the day, it's lower. So it's critical that the PCP and or other physicians involved with the care of the patient engages with them. MRA scores or HCC scores, you want the scores as it relates to your overall performance going up or remaining the same. If your scores are going down, that's not good as it relates to you and your benchmarks and your performance. An important thing to everybody has to remember, chronic illnesses do not resolve. They are managed or they get worse. And for success, they need to be managed. I'm a believer that best medical practices and utilization drive the overall cost. And that determines how well or how poorly you perform financially. Now, what do I mean by that? I believe if you do the right thing at the right time for the right reason, it will be less expensive for the total cost of care than ignoring that and having it done on an emergent basis or when the patient deteriorates. I believe that seeing the patient 4 times a year in the office for whatever the cost of that office visit is less costly than a half of one ER visit. So it's critical that we utilize the best medical practices associated with a lot of the things that we know as it relates to, say, choosing wisely, because that's better for the patient, it's better quality care, and it's more cost effective. How we treat the patients ends up determining the total PMPM. And the PMPM by the group then gets rolled into the PMPM or the overall cost of care for the ACO. I think you need to keep a handle on what is your professional, your facility, your ED, your outpatient facility, and your hospice costs by the overall entity and also by the TIN, because you could be performing well, but you might be performing better if not for 1 or 2 groups within your organization. The key performance indicators, the mix of healthy versus sick or chronic patients. You don't want a healthy ACO. You want sick patients in the ACO. There's very little you can do to make a 66-year-old person with hypertension better. So you want patients that have chronic illnesses because those are the ones that you can improve on. Transition of care, you want to be able to measure that CPT code or other professional codes that would show that the patient was seen. You want the readmission rate less than 50% at 180 days. You want all chronic patients seen each quarter. You measure it by the entity, you measure it by the group. You want to trend the annual wellness visits by month and then see how they do over the course of a year. You want to look at in-network versus out-of-network utilization. You want to see the patients that you lose, the number of patients you start with, and the patients you lose. You want to follow the overall MRA or HCC. You want to look at the admits per thousand, the ED visits per thousand, the imaging PMPY, the PMPM, and the post-acute care PMPM. All of these are measurements that you can get out of the appropriate platform. It's hard to believe, but Abraham Lincoln made this quote way back when. And it's just as, you know, when you look at it, considering when it was done in the 1800s, and you think about where we are today, if you have the data, you have the knowledge. If you don't have the data, if you can't organize the data, then basically you will be behind the 8 ball. Whether it's Clinigence Health or some other vendor, you want that vendor, that technology vendor, to be the integrating resource between the provider and the payer, between CMS and the ACO, or between the ACO and the providers. Because at the end of the day, you want physician engagement, and physician engagement leads to better patient engagement. The 2 technology platforms that I think high-performing ACOs should consider. One is a robust analytic platform, and the newest one that's coming into vogue now is remote patient monitoring. What is required of your technology? You should be able to do quality improvement, episodes of care. You should have provider performance scorecards. You should have predictive analytics and risk scoring. You should have the ability to pull out the key performance indicators. You should be able to, if you're going to be using the platform for GPROs, reporting, etc., is EMR integration. You need population health, and you use a platform such as that for it, and quality measure reporting, and just as importantly, cost and utilization. There are lots of different platforms. You want it to have ease of use, which I believe we've done within our platform. You want to provide that transparency, payer provider, or whoops, sorry about all of that. Payer provider, CMS to ACO, or payer to multi-providers, or a provider with multi-payer. You want to get automated insight delivery. In other words, you want certain things to be generated, on a frequent basis. And you don't want to spend a year integrating. You want rapid speed to value. As far as remote patient monitoring, I think the ability to passively monitor a patient allows doctors to identify patients who are deteriorating before they require an ER visit or a hospitalization. Now, there are medical wearables, there are Bluetooth-enabled devices, and there are apps with dashboards. Use cases for RPM: congestive heart failure, the scale; COPD, the oxygen saturation monitor. Recent discharge from the hospital, let's say we're dealing with somebody that was discharged with pneumonia. You want them to have a wearable to measure oxygen saturation plus temperature and pulse. Uncontrolled diabetes, you can hook up to the continuous blood sugar monitoring devices, or you can hook up to the old-fashioned ones where you prick your finger. Blood pressure treatment adjustments, there are wearables today that give you, again, passive blood pressure readings. And cardiac rhythm issues, again, this isn't the alternative to Holter monitoring, but it's very simple to see whether your patient is an AF or not an AF, or has an arrhythmia or doesn't have an arrhythmia, based on the treatments that you're doing. So I think in a future webinar, we'll be talking in more detail about RPM, but I think it's the newest advance in technology for organization. And how do all of these pieces come together? The idea is to identify opportunities to improve the care of your patient. And by improving the care of your patient, you'll reduce the cost of care. And when you identify these opportunities, whether they be patient-driven or physician-driven, you have to act upon them. Because again, there's a steep price for doing nothing. I think I'm going to end now, and if anybody has any questions, happy to take any questions.
Okay, great. Thank you, Dr. Schimmel. Yeah, we do have a few questions that came in, so in no particular order, I'll go ahead and ask you a few here. The first is, what is more important, controlling cost or providing quality care to the patients?
I believe the two are tied together. If your PCPs and your doctors are engaging their patients and increasing professional cost, you will be decreasing your outpatient facility and inpatient facility costs. So in my opinion, if you do the right thing for the right reason at the right time, there'll be that initial cost, but the overall cost will go down. Now, you have to measure ED rates per thousand, imaging rates per thousand. You have to measure your admissions per thousand, readmissions per thousand. All of those are cost centers. And you want to see, are there doctors or are there patients that are outliers? Because you have to figure out why. Why is someone going to the ER so much instead of going to their doctor? Why is Dr. X ordering an MRI and everybody walks in his office with back pain, when the best medical practice in choosing wisely is to wait 6 weeks? So I think they're tied hand in hand.
Okay, great. Second question here is, since physicians control the vast majority of healthcare dollars spent, how should ACOs construct physician member incentives to reduce healthcare costs?
That's a difficult question because everybody does member incentives differently. There are companies around the country called member engagement companies that offer incentives that go from debit cards with dollars to points, for other people on different programs. So I think depending on the financial resources of the organization, you have to determine how you want to incentivize those patients. But I think more importantly, it's the doctor that will engage with the patient. I mean, a larger organization might have a member engagement team, but if the patient is seeing their doctor frequently, then 4 times a year, let's say, you're seeing your patients to check in them how they're doing and make sure everything's all right. That's as good a member engagement as you can get. Now, you're going to have a delta. There'll be some patients that just don't come in. And there'll be some doctors who just don't ask their patients to come in. It's how you address both of those sides that will determine your success or failure.
Great. Okay, third question is, how can best medical practices be visualized to reduce cost and improve the quality of care?
Okay, so there's an organization called the American Institute of Medicine, and in conjunction with, I believe it's 60 different specialty boards, they created the Choosing Wisely criteria. Now, Choosing Wisely is procedural-based best medical practices. And there are Choosing Wisely criteria for every specialty. And you can download the whole, I think it's 450 Choosing Wisely ideas and look at them. But I'll just give you an example. The American Board of Internal Medicine, the American Board of Family Practice, American Board of Neurology, Orthopedics, and Neurosurgery came up with the following Choosing Wisely criteria. No patient who comes into their doctor with a diagnosis of back pain without some neurologic sign or symptom should have a radiographic or any type of X-ray procedure for 6 weeks. The recommendation is physical therapy, analgesics, muscle relaxants, etc. You would be very surprised at how many patients, and I'm thinking about all of our clients that we have, whether they be commercial, Medicare, ACO, IPA, MSO, whatever it may be, that back pain Choosing Wisely criteria is one of the top 2 in every group. And when you consider the cost of an MRI, and I will tell you, MRIs and CTs are ordered in a more frequent basis than plain X-rays of the lumbar sacral spine or whatever area they're talking about. So there's a best medical practice that, if followed, will improve the care of the patient based on all of the specialty boards, and at the same time reduce the cost of care.
Wow. Okay. The final question that we have that came in here is, have you found patient compliance/engagement varies by the type of patient membership in a Medicare, Medicaid, or commercial population? And if so, how do you increase patient cooperation in low compliance populations?
So the answer to that is yes. The Medicaid population is the least compliant. Commercial and Medicare, I would say, are almost equivalent. A lot of the commercial plans or employer groups do have some kind of member engagement consideration. Depending on the demographics of the organization, member engagement companies provide rewards for the patients who go to their doctor, who get this, who get that, etc. Medicare is a little bit different in the sense that you're dealing with an elderly population. They're, for the most part, not employed. They're not dealing with, a human resource person. And a lot of the ACOs or even small Medicare risk groups, they don't, or can't afford to hire a member engagement company. So the trick there is the physician. And again, I have found that and again, I'm going back to when I was practicing, I never had a patient that I said, I'd like you to come in because I want to just check and make sure everything will be all right, or I'd like you to come in for a follow-up in 3 months. I won't say never being an absolute, but I would say 90 to 95% of the time the patients came. So I think it's a matter of the physician building a rapport with their patient and stressing the importance of coming in, because nobody wants to get sick. Nobody wants to have to go to the emergency room, be admitted to the hospital. So I think the Medicare population, especially as it relates to ACOs and Medicare Advantage risk groups, they have, they have an easier time, I believe, of getting their patients to comply. Commercial, when you're 40 years old and you're healthy, you feel omnipotent. I'll come in and see the doctor in a couple of months. But it's as you get older and you start feeling the signs of aging and you start having the, pre-diabetes or the essential hypertension or even type 2 diabetes, those are the patients that I think it's easier to engage with.
Okay, great. Well, very good. Well, that wraps up our questions for today. Thank you, Dr. Schimmel, again for the presentation. It was very helpful. As we conclude, I would like to encourage you all to visit the Clinigence Health exhibit booth on ACOexhibithall.com, and you can learn more about them and connect with their team there. And also, ACO Exhibit Hall is